Good morning, everybody. Honorable members of the Pharmaceutical Society of Kenya, our guests from other cadres, our distinguished panelists and moderators this morning. My name is Daniela Munene, and I'm the CEO of the Pharmaceutical Society of Kenya, and I'm very pleased to welcome you to this edition of our Pharmacy COVID-19 Dialogues. We have an exciting panel lined up for you, and we'll get into it straight away. So I'd just like to introduce our moderators who will take us through the program. Our moderator, you're familiar with him, Dr. Michael Mungoma. He's a member of PSK. He's also the Dean, School of Pharmacy at Mount Kenya University in Thika. And he's a member of the PSK NEC, and I'm a member as well of the PSK COVID-19 Response Task Force that is the body that organizes these webinars. Karibu sana, Dr. Michael Mungoma.
Good morning, thank you.
Thank you. Our next moderator, she's very familiar to almost all of us, Dr. Sylvia Opanga. She's an active member of PSK. She's also a senior lecturer at the School of Pharmacy, University of Nairobi. She's also the chair of the Education and Public Health Committee of the PSK COVID-19 Response Task Force. Welcome to this forum, Dr. Sylvia Opanga.
Thank you very much, Dr. Daniela.
Over to you, Mike and Sylvia. Thank you.
Good morning, everyone. Thank you for attending our webinar today. So I'm excited for this webinar because we have our friends over from South Africa. And before we start, we have a few ground rules and announcements. Participants are all muted during the entire course of the webinar. Please ask questions via the Q&A tab at the bottom of your window. Please don't ask questions in the chat box. And these questions shall be addressed by the panelists later in the program. For PSK members, if you've not already done so, please subscribe on the PPD portal for today's webinar so that you can get your CPD points. For KPA members, the attendance list will be forwarded to the officials for awarding of CPD points. Please note, CPD points will only be awarded to paid up members, and this webinar is being recorded. The audio will be made available on PSK YouTube page for future reference. Next, Peter. So let me go straight ahead to introduce our speakers. Our first speaker is Professor Natalie Shellac. She's a registered pharmacist, a professor, and currently the acting dean of the School of Pharmacy in Sefako Makato Health Sciences University, located in Pretoria North, Gauteng province in South Africa. She holds 3 degrees, 2 bachelor's degrees, one in nursing and the other in pharmacy, and she also has a PhD in pharmacy. Outside the university, she serves on the Gauteng Provincial Pharmacy and Therapeutics Committee, and nationally, she serves as a member of the Tertiary and Quaternary Expert Review Committee for the National Department of Health. Her research interests are centered on the broad area of clinical pharmacy as related to pediatrics, ototoxicity, and infectious diseases, for example, TB and HIV. More specifically, she's interested in quantifying antimicrobial utilization data, pharmacokinetic and dynamic levels of antibiotics in blood levels. More recently, her research area has been focused on finding innovative ways of measuring antimicrobial utilization using health technology. Welcome, Professor Natalie.
Thank you, Dr. Sylvia. Thanks.
You're welcome. Our next speaker is Professor Haneli Meyer. Haneli Meyer is a pharmacist by profession and professor in the Division of Public Health Pharmacy and Management at the School of Pharmacy, Sefako Makato Health Sciences University. She specializes in vaccine safety and vaccination as an important pillar of antimicrobial stewardship and rational medicine use within the field of public health pharmacy. Her research aims to strengthen healthcare services and improve public health. Haneli is a scientific advisor on pharmacovigilance, cold chain management, and logistics for the South African Vaccination and Immunization Center at SMU. She's also the chairperson of the National Immunization Safety Expert Committee, a ministerial advisory committee, and in this capacity serves on the National Advisory Group on Immunization. She's also my friend as well as Natalie. So welcome once again, Professor Haneli Meyer.
Thank you very much, Sylvia, for the nice introduction and having us today.
Great. So I'll take you through the program of the day. We'll start with Professor Natalie Shellac, and she'll be telling us about the role of the pharmacist in COVID-19 and what they've done in South Africa. And then Professor Haneli Meyer will tell us about vaccination amid COVID-19 and beyond, and the opportunities for pharmacists. After that, we'll have the Q&A session by the moderators and all the speakers. So I'll quickly hand over to Natalie to start. Welcome, Natalie.
Good morning, everyone. I see, wow, 167 people logging in. I think it's fantastic. So thank you. Yes, indeed. Sylvia is a good friend, and we've collaborated on another international project, and we've just remained friends. So I want to actually just also thank you, Dr. Sylvia, Dr. Mike, Dr. Peter, Daniela, for having both myself and Haneli Meyer here today. I'm really looking forward to sharing the role of the pharmacist in COVID, in the current COVID pandemic, and to share perhaps just a little bit of background on the virus itself and what, you know, the role of the pharmacist in this whole pandemic. And we've published a paper on the role of the pharmacist that I'm happy to share with you or after this presentation. So I'm going to share so let me just quickly find, I just had it, and then we can start. So strange. Let's open. Okay, can everyone see my screen? Daniela,
yes.
Sylvia, can you see it? Okay, perfect. Okay. So yes, so we're going to look at the role of the pharmacist in COVID-19. And I think what's really important is, I don't know what the situation in Kenya is, but in South Africa, we've had lots of fake news and fake messages around corona. And I always say, in questions of science, the authority of 1,000 may not exceed the humble and careful reasoning of an individual. So especially in this pandemic, this really struck home to me in that, you know, we as scientists have to be very careful in our reasoning and how we really approach corona, and especially when it comes to the pharmacist and the huge role that the pharmacist actually plays in this whole COVID-19 is well, certainly true in South Africa, is underestimated, and some figures have shown us that the pharmacist has got more than 30% likelihood of contracting the coronavirus. These are some of the studies that was done by our pharmacy council than any other profession, and the reason for that is that a lot of the patients now bypass the clinic, a general practitioner, and then knock and go to the retail pharmacy or the community pharmacy. So today I'm going to talk about the epidemiology. Then we're going to look at the virus, you know, and its modes of transmission and the incubation period. some symptom identification, some social media myths and misinformation I'm going to share with you as part of the publication, and I'll discuss some of this during the presentation. Some treatment guidelines, and I'm going to look at some of the latest evidence around the medicines that we are currently using in corona, and the interventions and counseling that the pharmacist can give to the patient. Okay, so where did we start? So when we look at where this virus actually started, it is actually a new virus, and on the left you can certainly see that it started now in Hubei, and let me just show you Hubei there. This is a nice publication that was published in Frontiers, and it was a new virus that was identified to be a novel coronavirus. So actually not a new virus, but a new type of coronavirus. And I'm going to talk about that in a little bit. And it was initially named the 2019 N for novel, CoV. So the corona and the capital letter V for virus. And then it was renamed to severe acute respiratory syndrome coronavirus 2. And the reason for that severe respiratory syndrome coronavirus 2 is because you'll see initially what they found is that the virus caused a group of pneumonia conditions. So it was pneumonia cases linked to this human seafood in this wholesale market. And then the disease is now referred to as coronavirus disease 2019 by the WHO. And the virus was suspected to have begun its spread in this Wuhan seafood wholesale market in this Wuhan region. However, some of the more recent literature is even indicating that there may have been some sparks of this coronavirus even earlier, if you look at that point there in November. But one of the very first claims was made in an article published in the Journal of Medical Virology. And initially, they identified a snake as the possible host. Then a second possibility was that pangolins could be the wild host. And then through the most likely possibility is that the virus originated from bats. But I'm going to talk about that in a little bit. So increasing evidence and experts are now collectively concluding that the virus indeed has a natural origin in bats, as with many of the other previous respiratory viruses, and I'm going to talk about that in the coming slides. So you'll see in December the 31st, right before 2020, China then alerted the WHO to several of these pneumonia cases. Then France confirmed their first coronavirus. And so the story grew rapidly. And I mean, if you think about it, today we are in July, 29th of July. So practically, we've only had about 6 to 7 months to really get to grips with what is happening in this coronavirus milieu. So the timeline of COVID-19 in China, when we compare it globally, I just actually wanted to show you China in keeping up with what is happening globally. You will see the major events was that on the 23rd of January, Wuhan was completely locked down. On the 30th of January, they declared the pandemic. And then until the 9th of March, 346 teams of medical workers of other provinces of China, 42,600 in total, went to aid the epidemic control effort in Hubei province since the outbreak. And then on the 9th of March, Italy was completely locked down. And then later on, it was a worldwide pandemic. First, I thought it was just the epidemic. But what happened with the drugs is that initially, they started using alpha interferon. So they started looking at immunoglobulins to manage this condition. Then they started employing lopinavir, ritonavir, and antiretrovirals, glucocorticoids, then ribavirin, chloroquine. As we all know, everything that's happening, and I'm going to talk about that now. Then the USA jumped on the bandwagon, Abidol and tocilizumab, which is part of the maps that I'm going to also discuss. But you can see also how the drug therapy evolved as this pandemic spread. And when we look at this in total, I just wanted to, when I looked at Kenya's stats and figures, so what you are seeing here that's rather interesting is the dark maroon little dots that you see here. On the left side, you've got the daily tests per million, the y-axis, and then the daily confirmed cases per million people. And you can see that when we look at Africa, Democratic Republic of Congo still there, Nigeria, Togo, Tunisia, Ghana, South Africa. But when we look at Kenya, interestingly enough, as compared to South Africa, so currently South Africa has 459,000 cases, and Kenya is only sitting at around 18,581. So really, as compared to South Africa, I think, you know, it doesn't seem as though it's, you know, it's that widely disseminated yet, and you guys can just correct me. But when we look at active cases for Kenya, 10,374, South Africa 165,191, deaths in Kenya 299, whereas in South Africa 7,257. But what I always tell the students is it's not really about the deaths. So even in Facebook, you'll see lots of people on social media are saying they don't understand why we are having all of these interventions because it doesn't seem as though many people are dying. It's not about the deaths, it's about the active cases. I mean, if you think about Kenya, 10,374 people are requiring extra and additional, at this moment, medical care, and 18,581 people been infected on top of the other burden of healthcare, on top of the burden of healthcare and the other diseases that countries are trying to manage. And even in South Africa, nearly 500,000 people are really relying on the healthcare system. They need to be actively managed and tracked. So it's a huge burden on any country's existing healthcare system. Okay, so on this slide, this is actually a very old paper. And why I'm saying, and I've included this, is because a lot of people think that Corona just started all of a sudden out of the blue. So sorry if you've got questions, I'm going to answer all of them at the end. I'm seeing there are questions on the chat box, but I'll answer all of them at the end. But what I wanted to tell you, this is a paper that was published in Nature in 2012 already. And what this actually shows you is the animal origin of human coronaviruses. So what you'll see here, on my point, is genetically diverse coronaviruses. So in other words, we have known of corona for a long time because corona means circle or queen or crown in Latin. So severe acute respiratory syndrome is a novel coronavirus, but not a novel virus. And it emerged through recombination of the bat severe acute respiratory syndrome related coronaviruses. So the bat that you've got SARS-CoV, and then this recombined virus infected different animals and humans and adapted to the host before causing this whole SARS epidemic. So that there initially was just a SARS epidemic. Then I don't know if you all remember, so SARS was also a huge epidemic, and then we had MERS. So this is the Middle East Respiratory Syndrome coronavirus, and this also likely spilled over from a bat to a dromedary camel. And both of these actually now, this HCoV, HKU1, it actually, both of them caused mild infections, these ones here, but in immune-competent humans, not immune-compromised. And progenitors of these viruses have recently been found in African bats that we've seen. And the camelids, interestingly enough, are likely intermediate hosts of these HCoV 22.9E and then 43 and U1, both of which are mostly harmless in humans that likely originated from rodents, as you can see there. Then recently, what we've seen here, so recently this paper, remember, was now published in 2012. So recently swine acute diarrhea syndrome, so that is swine acute diarrhea syndrome, emerged in piglets. And then this disease is caused by a novel strain of Rhinopolis bat coronavirus. And there was no evidence of infections in humans that we know of. So remember, the solid arrows now indicate the confirmed data and the broken arrows indicate potential interspecies transmission. The black arrows indicate infections in the intermediate animals, whereas the yellow arrows indicate mild infections in humans. And then the red arrows indicate severe infections in humans. So the only reason why I'm saying all of this to you guys is just to remember that there's nothing novel. It's not a novel virus. It's just a novel coronavirus. Even many years ago, we knew of the coronaviruses and we knew it can most likely, and we know MERS, we know SARS, it caused respiratory distress syndrome, but nothing like what we've seen here. So then what you can see here, so what really is in a virus? And what I want to show you is when you look at the viral structure, and for a pharmacist, it's really important to understand this because Hanneli is now, subsequent to my lecture, she's going to talk about vaccination. But what is important is to remember that Coronaviridae, which is now the complete family name of this, is a family of viruses with a positive sense RNA, and it has this envelope that you can see. It has this outer viral coat. And when we look at it under electron microscope, it appears to have this unique corona around it. So it's almost like a crown that we see. And the family of viruses that causes respiratory diseases in human, as well as a common cold or a pneumonia in respiratory infections. And we've said that they can also have effects in animals as well. So when we look at the clinical cause, fever, we see that mostly in around 88% of the population, dry cough 67%, and that may be because of the ACE receptor, fatigue 38%, sputum production 33.4%, dyspnea 18%, myalgias. We see a lot of myalgias in South Africa. Myalgias, people that it's got really, stiff and sore muscles, sore throat. So everything that you would more or less expect from an upper respiratory infection. And the disease severity really depends on the host's ACE receptors. But what is interesting, I'm going to talk about this in a little bit, is its ability to bind. So what you see here is this spike glycoprotein that you are seeing right there is what is responsible for receptor binding and membrane fusion. And we've got lots of drugs that act on that, and it's targeted by host neutralizing antibodies. And that's where vaccination modalities include these live attenuated viruses with this chimeric subunit nanoparticles for DNA and RNA vaccines. Okay, so when we look at COVID, and I've included a slide that, it may not look pretty, but I absolutely love this slide because it's really, really important in infectious diseases. And what you are seeing here at the moment, let me just move this away, is, no, this thing was just moved now, is, sorry, is when you have an inflammatory trigger. So an inflammatory trigger, remember, it can be anything. Your body must first distinguish whether it's a burn, if it's an endotoxin from a specific infectious origin, if it's an infection, or if it's an injury. Then the body of a host activates leukocytes. This is just a whole immune system or an initial immune system that is activated. Your leukocytes, lymphocytes, endothelial cells, and various parenchymal cells. So why is this important? This is really important because of the damage that corona causes on the endothelial cells, in other words, in the vascular system, and that is where we are seeing the activation of platelets that causes, it activates the platelets through glycoproteins, and that's where we see some of these vascular challenges that we're seeing with corona. But then we have this whole humoral response repertoire, and we have this cytokine storm that they talk about with corona. We've got the acute phase proteins here that we see, but only later in the inflammatory phase, which is almost too late. So we really want to start acting here on the endothelial cells, And that's where a lot of the targeted pharmacotherapy is. And then the stress hormones that is also released. And then it causes this local inflammation that you would see in anyone. The Latin terms are calor, dolor, rubor, tumor, and then function loss or functio lisa, which means it's red, swollen, cold and clammy, and then you lose function of that specific part, which is really what is happening in corona. Okay, so we have discussed the transmission cycle of COVID, but I want to talk about droplet, the transmission. And initially we thought that droplet transmission is the main mode of transmission when it comes to corona, but maybe about 3 weeks ago, there was a big study that was published, and the WHO has now adopted this, in that we know that it's also aerosol transmission. So why is that important? It is really important because droplets are a larger molecule. So when it comes to the role of the pharmacist in infection management, when you have a disease that is spread through droplets, it is almost easier to manage than a disease, for example, Mycobacterium tuberculosis, that is spread through aerosol transmission. The aerosol transmission is a smaller particle, and it remains suspended in the air for many hours, a lot longer than droplet transmission, because the molecule or the droplet is bigger, so it sediments to the floor quicker. So now that we know it's also aerosol transmission, we know that we need to be especially careful when we have patients with corona, and that we need to ventilate a room. And we, in managing Mycobacterium tuberculosis, what we've done is we've just opened windows, in clinics where we don't have a lot of funding and we can't afford fancy air cons and extraction fans and all of those, really great stuff. And so what we then do is we open up the windows so that some of the aerosols, or that the room can ventilate. And then contact transmission is when we know that the corona stays on a surface or in an inanimate object for a long period of time. It depends on if it's plastic or wood. And you may have seen, if you go to your cupboard, some of the older disinfectants, for example, Savlon or Dettol. If you look closely on some of these older disinfectants, you will still see they also have corona. But of course, this novel corona has got other spike proteins, which makes it novel. Okay, so I really like this slide because it actually just shows the pathophysiology of corona through either if it was fecal contamination or through respiratory droplets. And you can nicely see the S spikes there, which is really important, and that's what makes this virus a little deadly. So we know the incubation period ranges from 1 to 14 days, and the variation in incubation period is associated with the age of the patient. So above the age of 80, the patient usually develops the symptoms faster as compared to others. It may be because of the ACE2 enzyme and the number of ACE2 enzymes that the older patients have. But what is also important is the inoculate. So in other words, we talk about the inoculate. If you think about vaccination, sometimes we just give a small amount of an inoculate to activate the host cell's immune system. But what we are seeing with corona is that we suspect that healthcare workers become sicker because they've got a larger inoculate of the coronavirus versus someone who may have a smaller inoculate, and then based on the person's underlying physiological condition and the numbers of ACE2 receptors and their overall health is how they respond to it. So let's say if we look at this SARS-CoV-2, it affects the epithelial cells of the alveoli. So in other words, it enters the lungs right in there. And after the entry of the virus into the respiratory tract, the cilia of the alveoli in the lower respiratory tracts facilitates the attachment of the virus to its receptors. So there have been some speculations that patients that are smoking or who's got COPD, chronic obstructive pulmonary disease, and with less functioning cilia may have some form of protection, but we know it's not true because smoking also has a large inflammatory burden. Okay, well, multiple of these SARS-CoV-2 proteins interact with the components of your innate immune system, and that's what I've spoken about in the earlier slide, to evade an antiviral interferon response. Okay, the expression of your ACE2 receptors and the SARS-2-CoV receptor on the surface of the cells is then downregulated after infection with SARS-CoV. So what happens is your body starts downregulating these ACE2 receptors, and the mechanism of this downregulation may be due to the internalization of ACE2 during SARS-CoV entry and by the induction of tissue necrotizing factor converting enzyme that activates your metalloproteases. Okay, so the enzyme then cleaves this ACE2 extracellular domain from the transmembrane domain, and then it sheds its complete domain, and that makes it really difficult for the body to act on it. And this has led to this hypothesis that we currently have, is that the binding of SARS-CoV-2S, remember I spoke about that S protein, is a virulence factor for SARS above and beyond its role in viral attachment and entry. So when we look at patients with COVID-19, they show a very high leukocyte numbers, abnormal respiratory findings, and increased levels of plasma protein, inflammatory kinins. There we see all of that happening right there. You see all those interleukins, that is the cytokines. And the main pathogenesis of COVID-19 infection is in the respiratory system, because remember, the respiratory system is really, really rich in the ACE2 enzymes, and it causes the pneumonia or anemia combined with the incidence of acute cardiac injury right there because of its activation of the endothelial cells, where you've got systemic inflammatory respiratory syndrome, and because of the lack of oxygenation from the lungs, which places an extra burden on the cardiac system. And then in the brain, this whole system, the cytokine storm and the tumor necrotizing factor then also activates the hypothalamus to cause fever. Patients present with an increased heart rate. So the association of this worsening that we see here with declining virus loads and the onset of an immunological response, plus the presence of markedly elevated cytokines, suggests that severe lung damage is largely the immunopathological in nature. So it just means even after the virus load decreases, we know that there's damage in the lung fields, which affects nearly everything else. Okay. So I've included, this is actually a diagram that comes from the book from Gustav Schellack and myself. We drew this, and the reason from an undergrad pharmacology textbook, the reason why I included this, I know you're all pharmacists, is just because this is standard what we teach our students. I mean, if I could see you in front of me now, I'm sure a lot of you would nod. So standard as part of this is we teach our students that angiotensinogen, then which is a hepatic alpha-2 globulin from the hepatic system through the activation of renin, which is a proteolytic enzyme, is converted to angiotensin 1, which is inactive and requires the angiotensin converting enzyme to go into an active angiotensin 2 molecule. But what we sometimes neglect to teach our students is that you've got ACE1 and you have ACE2 enzymes. So I'm including this because we drew this, and as part of a pharmacology textbook, we don't always teach our students of ACE1 and ACE2, but what is important is that angiotensin 2, so ACE1, is responsible for the activation of angiotensin 2, and ACE2 is responsible for activation of angiotensin 1 to 9, but you have vasoconstriction, aldosterone synthesis, cell growth and proliferation, and these are some of the great effects that we really do want, is anti-proliferative, which relates to antitrophic effects in the cardiac system in vasodilation. So when we look at it physiologically, that's what I wanted to say, is what is beautiful about this system is that it's a double system. The body makes sure, and you must remember that ACE is circulating, within this, within the vascular system, especially in the pulmonary and renal endothelial linings. And if we didn't have these two-step mechanisms, then constantly, as we are moving around in our bodies, the angiotensinogen would constantly be converted to angiotensin II, and we would constantly have all of these sympathetic effects with vasoconstriction. So the body's got these two steps to try and protect us. So what is happening in corona? So what happens in COVID is you've got ACE1 enzyme there, and then remember it was renamed to SARS-CoV-2. So then SARS-CoV-2 then actually uses ACE2 as a co-receptor, and we need ACE2 to convert angiotensin 1 to 7, which gives us these vasodilation, anti-apoptotic, anti-fibrotic, anti-proliferative effects, which reduces your blood pressure, cardiac fibrosis, thrombosis, and acute respiratory distress syndrome. So you can see this is a double-edged sword. And the reason why I'm saying that is, if you have a lot of ACE2 enzymes, it can be good for your health, because you are negating all of these negative side effects that you are getting through angiotensin II vasoconstriction, the effect on your heart. But in the patient population that has a lot of these ACE2 receptors, there's also a lot of receptor sites for COVID to bind to gain access. So that is why there was lots of controversy around the non-steroidal anti-inflammatories, because the theory is, and with the ACE inhibitors, if we now block ACE1, then we are actually upregulating ACE2, and then we are having more receptors for the COVID to bind and enter the body. However, if you have an immune competent host, even if your inoculate is sizable, then your body is still healthy enough to manufacture enough antibodies to fight off the disease without having, for example, thrombosis or cardiac fibrosis or any of these other negative effects. I hope it's making sense to everyone.
Natalie?
Yeah. Yes.
Have much time, so I'll request you to.
Oh, I must hurry along. How much time do I have?
You have about 5 to 10 minutes. We started late.
Okay.
So
Yeah. Natalie, maybe 5 minutes at most, maybe 5.
5 minutes.
Thank you.
All right. Yes. Okay, let me try. Okay, so I've discussed all of these blood clots that we've seen, the endotheliopathies that we are seeing, and the cytokine storm. And I've mentioned lots of these signs and symptoms that may mimic many other diseases, and that we do see in COVID-19. The clinical presentation especially is mild, is mostly in about 80% of the population, whereas critical diseases is only in 5% of the population. In South Africa, this is more or less how we manage patients. We almost never only take a PCR, polymerase chain reaction, just for COVID, because we need to know as well if there's any other conditions. So we take microbiology, we look for other viruses, blood cultures, we do imaging, and we have to look at the labs and biomarkers for the reasons explained a little earlier. So we have to wear masks during this coronavirus pandemic, and it's a big role to play. Our South African Pharmacy Council has actually mandated patients, they have to wear masks when they visit the community pharmacy. And I just wanted to show you, this is where we are. This broken line is this is the healthcare system's capacity. So we use this also in educating the public to say that if you don't wear protective measures, the daily outbreak peak is going to increase, whereas, and it will be beyond the capacity of our healthcare system. And this just shows that mostly the primary presenting symptoms is a lot, and the major complications are only those ones that you see in critically ill patients. Has to be safe distancing with aerosol transmission, even more. We work from home in South Africa. A lot of us work from home. Because we are not very rich in all of our settings, we tend to rely very much on, teaching the public how to cover with a napkin or elbow, wash their hands, or air a room. And we also teach hand washing to be proper, through all of the fingertips and the palms. And just something else that's important to share with your public, if we don't have different stages of lockdown, one person will affect 2.5 people in 5 days, and in 30 days, 406 people. Versus if you go down staging, 75% less contact, one person only affects 0.625 people, and in 30 days, 2.5 people. So you can see it's a huge difference. This is social distancing measures that you could just use. Okay, I'm just going to spend my last 3 minutes just on what is good for scientists to know about COVID. It's a great race, actually. And what is beautiful, actually, is just to see that we have these 7 repurposed drugs. We've developed 16 antibodies and 43 vaccines, with Moderna leading at the moment. But what we can see is the repurposed drugs, mostly for Ebola, HIV, malaria. We don't really use chloroquine. It's not advocated by our Department of Health. We're now looking at colchicine, which are anti-gout. The antibodies where we used Y-shaped proteins to stick to the virus, and we use it through recombinant technology and inject it into the patients to prevent or reduce the infection. And Annelie is going to talk about vaccines. Okay, so when we look at these drugs, let me just quickly talk to you about this. It's important to know if you are going, where do you need to use your drug? Are you going to use it in the viral response phase? Are you going to use it in your pulmonary phase? Or are you going to use it in your host inflammatory response phase? And it really depends on what your patient is presenting with. So I've spoken about the non-steroidal anti-inflammatory drugs and the controversy. We still don't really advocate in South Africa to use it. However, in severe fevers, you can consider it, but we use paracetamol. We are continuing our patients on angiotensin-converting enzymes if they are stabilized on it. Okay, so then when we look at lopinavir and ritonavir, so lopinavir and ritonavir are our antiretroviral drugs that we are using. And what is interesting about these antiretroviral drugs is just maybe to know that both of these drugs, both lopinavir and ritonavir, are inhibitors of your proteases of coronavirus, the protein that cleaves your large body proteins into smaller functional units. And it does seem to be working anti-coronavirus in vitro and in vivo. Oseltamivir, it's mostly kept for influenza. We only use it in patients in the ICU where we don't know what the pneumonia origin is from. Ascorbic acid, anecdotal evidence, none in coronavirus. Corticosteroids through the recovery trial has shown great benefit in critically ill patients due to its immunomodulatory effect, mostly dexamethasone because of its mostly anti-inflammatory effects. Then the MABs that we are using. So all of these latest MABs that we are currently investigating is really based on its effect on anti-interleukin 6 receptors, monoclonal antibodies, and it has shown great promise in immune modulation. It's all of these other MABs. And then remdesivir is actually a drug that was registered for Ebola. And then with remdesivir, it's a nucleoside analog, and it inhibits the RNA replicase, polyprotein 1b, and it was used in the very first patient in the United States, and since then has really shown great promise. Okay, this is just to show that one must remember that we are also activating this system, arachidonic acid, and that's where the corticosteroids and the non-steroidals act. And the clot thickens, we are starting in South Africa to really start with early intervention of low molecular weight heparins because of its endothelial toxicity of the virus. And then can we teach an old drug new tricks? And that is where we are really starting to use colchicine in patients. I don't know, are you guys also using colchicine in Kenya? Right, okay, so it's actually an inhibitor of mitosis that you can see right there, and the microtubule assembly. So, and because this is involved in many cellular processes like cell division and cell shape, it actually prevents replication of the virus, which is good. And we also see it acts as a neutrophil chemotaxis, so it manages inflammation and viral replication, and it has actually shown great promise. So we are leaning more towards colchicine. The vaccine timeline, I'm going to leave that to Annelie, but I'm really finding this very fascinating that we are, racing against time for this vaccine, and it seems as though Moderna is winning with a novel sort of dosage form that sounds great. Okay, so the role of the pharmacist, and you can see that this is really my last slide, but I just want to say, and I've discussed the pharmacist throughout my presentation, but in South Africa, one of the biggest roles of the pharmacist is really in educating the public, providing really good guidance, giving symptom management when necessary, providing the patients with the appropriate resources of where they can go, remaining up to date. But another big role that we discuss in our publication is where we talk about emergency pharmaceutical care. So emergency pharmaceutical care is where we say that the other conditions apart from corona should not be left behind. In Ebola, a lot of the patients didn't die necessarily because of Ebola, but because the other conditions, diabetes, hypertension, etc., were actually neglected, and the patients did not receive their medication. Okay, thank you everyone. Thank you for your time. It's much appreciated. And good luck, and I hope all of you keep safe in this time.
Thank you so much, Professor Natalie, for a very stimulating presentation there. There's quite a lot. I think it's very packed and very, very useful. I think there's quite a lot there we need to engage in. I think I just want to jump in straight and invite Professor Hanneli Meyer to do her presentation, and then we'll take questions and answers for both presenters. Participants, remember that you can send in your questions through the Q&A section at the bottom of the screen there. Yeah, so send in your questions early enough so that we don't have questions coming in at the very end. Thank you. Professor Hanneli.
Thank you very much. And thank you, yes, everybody again for inviting us today and giving us the opportunity to speak. So from my side, yes, I love speaking about my passion, which is vaccination. And I hope I'm going to share some exciting things from South Africa with everybody on this webinar. So this is just an outline. In the interest of time, I'm not going to elaborate on that. So at first, I just want to give you a little bit of background in addition to what Natalie has already given you about South Africa. So as you can see there, we've got an estimated population of nearly 60 million people. And our population is actually quite young, with nearly 30% of them being under the age of 15 years. Then, very importantly, we have a two-tier healthcare system, and actually very, very unequal, with only 16% of the population accessing the private sector healthcare and 84% of the population accessing care in the public sector. So hopefully with, as we are moving towards universal health coverage and our national health insurance system, we will be able to balance out all these inequalities. So how do people actually access vaccination in South Africa? So in the public sector, vaccination is provided mainly at primary healthcare facilities, which include clinics and community healthcare centers. So clinics meaning, primary healthcare clinics throughout the whole of South Africa, community healthcare centers, which are a little bit bigger. And then also at hospitals, mainly at outpatients departments, but also at within other departments, depending on the level of care that the hospital is providing. Then in the private sector, vaccines are provided at private clinics, clinics within pharmacies, private pharmacies, as well as pharmacy groups, in hospital, in general practitioners, doctors' rooms, specialists like, for example, pediatricians and others, then our private sector hospitals, as well as travel clinics. So who are the vaccinators in South Africa? So vaccinators are healthcare professionals, mainly nursing professionals, also medical practitioners, and then pharmacists also have vaccination rights in South Africa within their scope of practice, provided they can provide evidence of competence in that specific area. So in terms of the vaccination schedules in South Africa and routine immunization, so on this slide you can see the routine vaccination schedules for South Africa. So on the left-hand side, we have here the EPI schedule, which is being used in the public sector in South Africa, but then we also have a private sector schedule. So in the public sector, vaccines are provided free of charge for everybody. And like I said, it is mainly nurse-driven. Then in the private sector, those vaccines are, some of them covered by the medical insurance of the patient. Otherwise, it is out of pocket. Then, yes, all children are also provided with a Road to Health booklet, which is actually a whole booklet with comprehensive care as the child is growing. So to improve access to these public sector EPI vaccines in South Africa, which is very important, there is now a service level agreement that can be signed between the private service provider and the Provincial Department of Health. The private sector provider can then levy an administrative fee for the client or the patient. But then there are also requirements in terms of the physical space, data that needs to be provided, adverse events following immunization must be reported, as well as then the qualification of the vaccinator. Then we also have a human papilloma virus HPV vaccine program in South Africa that is supplied or provided within the integrated school health program. So 2 doses, 6 months apart, is provided to girls in grade 4 or from now on actually grade 5 at the age of 9 years. And this is free of charge in the public sector. So when it was rolled out, the program in 2014, the uptake was quite good for the first dose at about 86.6%. But since then, actual numbers has been reported, and there is a visible decline of about 20% between the first dose and the second dose. So in other words, the second dose uptake is not as good as the first dose. Then when it gets to private schools, that's actually a challenge because it's not provided free of charge to those girls, so it is out of pocket. Also, you know, the normal, like you see the information on the screen, is obviously not provided to those children because they are in private schools. So according to a recent national survey, the uptake was found to be actually very low, only 19.4% for those private sector girls. And then reasons provided for not vaccinating, 65% of them related to vaccine hesitancy, which is quite worrying. When it comes to adult vaccination, we do not have an official schedule in South Africa. So this schedule can be accessed at the link you see here on the screen. So it's recommended vaccines for adults and those over 19 years. And then as you can see there where I have the little red faces, these are the vaccines that's recommended specifically for the elderly. So within the private sector, the public sector, sorry, within the public sector, the only vaccine that the elderly can then actually access is the influenza vaccine within the public sector. The other vaccines, should there be certain cases or if they are identified as a high-risk person, then they would access these vaccines within the public sector. So we also have an influenza vaccination campaign each and every year within, throughout the country. And now specifically, I'm talking within the public sector of South Africa. And since this has changed quite a bit as a result of COVID-19, so when our first cases of COVID-19 were identified, on 24 March, the National Department of Health issued a specific guideline for influenza vaccination in South Africa this year, as you can see here on the left-hand side. And for the first time in South Africa, vaccination of healthcare workers is actually mandatory. although this was not really enforced in South Africa due to a number of reasons, but healthcare workers were then identified as the #1 priority of receiving the influenza vaccination. But now it's very important for us to remember that healthcare workers are those who work in the front line. They are the ones taking care of patients, especially now during the COVID-19 pandemic. So they are at an increased risk of exposure to infection with influenza as well as with COVID-19. And they're also at risk of actually transmitting the infection to susceptible and vulnerable patients. So there's always a lot of discussion going on about, you know, what are the implications of mandatory vaccination. But we need to remember as healthcare professionals, we actually have a professional as well as an ethical responsibility for the sake of patient safety. So this is very interesting now for influenza vaccination this year in South Africa. So on an annual basis, our National Institute for Communicable Diseases, they publish some guidelines specifically for influenza. And these ones in red, these groups in red, they are prioritized by the National Department of Health. But for this year specifically, these 5 groups were identified as the target groups. And as I said earlier on, that healthcare workers is actually the #1 group, followed then by our elderly, those with cardiovascular and chronic lung disease, pregnant women, and then HIV-infected patients. So interestingly now, is if we look at the utilization of influenza vaccination in South Africa, so in the public sector, the estimations were done based on historical demand. As you can see, there are just over 1 million doses. So by the end of February, these doses were delivered, and then COVID-19 appeared on the scene. So the National Department of Health actually requested an additional 2 million doses. And that was difficult to source. So the suppliers tried to source from other Southern Hemisphere countries. And eventually, a total of, as you can see, the 1,278,000 doses were supplied to the public sector. So as you can see, this is a 20% increase on initial demand, and it's a 27% increase from last year as well. So now what is interesting, I mean, utilization is still continuing within the public sector in South Africa. So based on these doses distributed, you can see healthcare workers, which is actually our #1 priority, is not #1 in terms of utilization. As you can see, the HIV and AIDS is who is actually identified as #5 in terms of priority. Most of these doses have been used by them. So also we have evidence of low influenza vaccination uptake, which is actually known amongst healthcare workers. A recent study in primary healthcare clinics found only a 28.7% 2018, and in a tertiary hospital only 20.6%. So as you can see, there is a huge gap in terms of that. So in the private sector, similarly, about 1.3 or even more doses have been already distributed to the private sector. And the demand there was actually more than in the public sector, coming from the public themselves. At first, as you can see, one of the private groups reported that they have been administering 4 times more flu vaccines this year. But now, like in June, you can see flu vaccine elusive for some. So there is now a shortage of these vaccines in South Africa. So what about pharmacists? We as pharmacists. Pharmacists play a very important role, especially now during COVID-19. So as you can see from these tweets, that pharmacists, we are frontline workers in South Africa, especially in terms of influenza vaccination, you know, which is available to the public also in private sector pharmacies. And as you all know, pharmacists were celebrated actually in 2018 during during Pharmacy Week as, you know, worldwide being leaders in vaccination. So pharmacists play a very important role because we are mostly the first point of contact with the patient within the healthcare system. Okay, so this is just an example of a vaccination, influenza vaccination campaign we had last year at our university, coming from our school. So you can see here that we were able in the end to actually distribute or administer 1,000 doses. So this is a collaborative effort that we take, or that we put in place with our students, our school, with SAVIC, as well as the EPI program within the Tshwane district area. So now, if we look at the COVID-19 pandemic, so as you all know, on 3 January, the World Health Organization declared the COVID-19 outbreak as a public health emergency, and soon thereafter, on 11 March, it was declared a pandemic. So since then, most countries actually went into a lockdown period, with South Africa as well, starting 26 March, and then it was extended. So within strict lockdown regulations being implemented to actually limit the rapid spread of the virus. So on the one hand, the lockdown has been very effective and life-saving, a life-saving intervention, reducing the expected exponential increase in infections, and in South Africa, flattening the curve. However, on the other hand, we need to ask the question, because it's also a costly intervention, and it actually has huge negative economic and social impacts on households, with our government spending billions of rands to provide assistance to various levels of society. But the question is now, how do you maintain this balance, and at what point do the costs actually outweigh the lives that we are saving with this intervention? So a question then that is asked, and it was asked by these authors, what about the trade-offs being made within the healthcare as services are now focused on COVID-19? And, can we actually afford to make these trade-offs, especially when it comes to children and those things that affect children in our various countries, especially in South Africa, where we are a country with 5.8 million children under the age of 5 years. Also, considering the fact that children appear to be less susceptible to COVID-19 and also appear to not be the super spreaders of the virus, is it possible now that avoidable deaths from vaccine-preventable diseases will soon outnumber the COVID-19 related deaths amongst children? This is a question that we are asking. And then, can we actually afford a dangerous vaccine-preventable disease outbreak, such as measles during the COVID-19 pandemic? So, here you can see evidence of outbreaks we've had in South Africa without, another epidemic being present. So can we afford for this to happen whilst we are still within the COVID-19 pandemic? So, in terms of, sorry, let me just go back, yeah. So here you can actually see the risks that we are facing for, to experience a vaccine-preventable disease outbreak. So firstly, our young and poorly nourished children, they are at higher risk in South Africa, and this applies to 27% of children in South Africa. Should we have interruption in our immunization schedule, there's a higher risk of outbreaks. Then also, when we look at vaccination coverage over the last number of years, and if we look specifically at our fully immunized coverage, or our FIC, which refers to children under the age of 1 year who has received all their scheduled vaccinations up to the first dose of measles, it has been below the WHO target of 90%. As you can see, it's fluctuated over time, and 2018, 2019, we were at about 82%. So here are just some more examples of collaborative efforts from pharmacists in South Africa. So this was in 2017 when we at SMU collaborated with the Pharmaceutical Society in South Africa, and we actually launched the Pharmacy Week initiative at this taxi rank or bus rank in Mamelodi in South Africa. So these campaigns actually take place on Saturdays. So we go to shopping centers, taxi ranks, and so forth, and we make vaccines available to mothers, caregivers who are not able to go to these clinics during the week because they are only open during the week in the public sector, and then they can access vaccines on these weekends for their children. So in 2017, you can see here, I've got some data. We reached more than 1,000 children, vaccinated 913. Very interesting that the 2 events we hosted in the most resource-limited areas contributed to nearly half of all the children that we reached. So all these were children vaccinated, children who actually missed their vaccinations. Here you can see in 2018, we had another campaign, and we provided all children with a very cute little fridge magnet, which they could put on the fridge to help them, the mommies remind them or the caregivers to take their kids for vaccination. Again, in 2019, we had our annual vaccination campaign. And as I said, it takes place in collaboration with our local Tshwane District EPI program, as well as with some other partners, as you can see here, and organizations supporting this initiative. Unfortunately, our 2020 campaign has now been hijacked by COVID-19, but it won't stop us to continue next year. So now, what is the impact on children, COVID-19? So in June, this report was published on the cost of COVID-19 school closures in South Africa and the impact on children. And they actually referred also to the issue of children not being immunized. And just a couple of days later, we saw in the news a dramatic drop in South Africa's immunization rates. So this table shows you the negative impact COVID-19 had and the lockdown in South Africa had on our routine immunization uptake within the public sector of South Africa. So, I mean, these data here is provisional. So it's not a year for reference. But as you can see, if we compare 2019 to 2020 and we look at the first 3 months of the year, you can see that the vaccination uptake rates were fairly similar, and in some cases even better in 2020. However, when it came to April 2020 during the lockdown, you can see a decrease of around 20% in all these important indicator vaccines. And this includes measles, which is a very dangerous vaccine preventable disease. So although it seems like in May, the picture is looking a little bit better with some measures being put in place, there are still many, many children missing out on the eligible vaccines. So with the current situation with COVID-19 in South Africa as well as elsewhere in the world, the response to the pandemic has placed really a huge burden on our healthcare system for a number of reasons. Healthcare workers not being available, being sick, restrictions on travel, lack to PPE, redeployment of healthcare workers to other duties. And while that's taking place, on the other hand, we've seen a decrease in the demand for vaccination, also for a number of reasons, including physical distancing, lack of information, fear of infection, transport problems, community reluctance, and so forth. So these disruptions resulted in an overall disruption in our immunization services and a decrease in vaccination coverage, like you have seen on the previous slide. So when this happened, there's lower herd immunity, and there's an increase in the number of susceptible individuals. So this then increases the likelihood of an outbreak of a vaccine preventable disease, and who's at most risk is our young infants and our vulnerable groups like those over the age of 60, for example. So when this, if should we have a vaccine-preventable disease outbreak, we will see an increase in morbidity and mortality, and again, placing more burden on our healthcare system. And I'm asking the question again, can we actually afford this? And the answer is no, we can't. So what's happening in South Africa is happening also across the world in many other countries. And we've seen in this publication that more than 50% of these countries have actually reported that they have seen a decline in vaccination coverage rates. So while vaccination is considered the most cost-effective public health care intervention ever, second to clean water, the Director General of the World Health Organization warned that this disruption to immunization programs by the COVID-19 pandemic threatens to unwind decades of progress that we have made against vaccine-preventable diseases. Also, the Executive Director of UNICEF said that if we do not restart immunization services, we risk exchanging the one deadly outbreak for another. And that is not something that we want to see. So the World Health Organization then published some guidelines for immunization activities during the pandemic. And also South Africa then followed from our NICD side, also with some specific guidelines. So with these guidelines, both of them is a call to action for all vaccinators. So across South Africa, we need to continue with our routine immunization as an essential service. So it basically means all our immunization services must be operational, as it is a core health services. The prevention of vaccine-preventable diseases, we prioritize them. Surveillance is very important to continue because we need to see what is happening with our vaccine-preventable diseases, as well as with COVID-19. Newborn vaccination must continue in all hospitals and in obstetric midwife obstetric units. Strategies must be adapted without any undue harm to healthcare workers, very important. And then all healthcare workers must be prioritized, like I've already said, in terms of influenza vaccination. So with routine immunization continuing, certain measures and precautions must be put in place. We need to have human resources, sufficient vaccines, PPE, infection control measures, and supplies. And this is where the pharmacist now plays a very important role as well, especially those also in community pharmacies. So when it comes to delivering immunization services, COVID-19 transmission must be prevented at all times. So firstly, our patients should be scheduled for appointments to prevent long queues and overcrowding in waiting areas. That can also be done electronically. Social distancing, like Natalie has already referred to, must be in place. We need to triage and our patients and have separate queues for children. Hand hygiene is super important. And then lastly, cloths must be worn at all times by parents as well as by children, except for children under the age of 2 years. So another measure that we have put in place is to request all road to healthcare booklets to be checked for any missed immunizations. And this must take place at all facilities, private practices, pharmacies, clinics, hospitals, it doesn't matter what. Catch-up vaccination must be done immediately for all vaccines where the child is age eligible, unless there are specific contraindications, and then strategies to follow up and track on missed vaccination. So this is also where pharmacists can play a very important role. So yes, just some smart COVID principles. I'm not going to spend time on them now, but for each and every one of these letters, we have a word. So something that I want to mention, we need to make sure we can, and that's where pharmacists can also play an important role, is to make sure that we prepare our patients coming in for consultations. And then something else is to encourage the caregivers not to come with the whole family when they come for vaccination, just for one person to bring the child, because it just increases the risk of exposure as soon as you have, the whole family coming and then making it a kind of an outing as they used to do. So re-establishment of our immunization services, very important. We need to close those gaps. And as I said earlier, prioritize for vaccine preventable for diseases which are prone, where we could see an outbreak. And there are also innovative methods that are being implemented in South Africa at the moment in collaboration with many organizations. So examples is schools or day centers can be identified for sites. School nurses, volunteers can help retired healthcare workers, mobile vaccination posts. Public-private partnerships are very important, and we are seeing it now happening in South Africa. And then to make vaccines available in the private sector, as I said earlier on, we have service level agreements that can be signed with the Provincial Department of Health. So what is very, very important, and that is where the pharmacist plays a very important role, is in effective communication strategies. To communicate with the patients and speak to them, especially pharmacists, where they are usually the first person that a patient would engage with or access for healthcare. And to actually communicate and allay any concerns that there could be with regards to vaccination. And as you can see here, we want to see vaccine confidence amongst our patients. So here are some examples. We've got a side-by-side campaign. They are very actively involved on social media, on Twitter, on Facebook, and they also have radio programs that's now running nationwide on many radio stations. Also, when you go to their website, you can link with all these various applications, including Mom Connect, Nurse Connect. You can find the posters and get all the information from there. Another one is Messages for Mothers, where they actually target, the child as with a holistic approach, and then they share these messages. They're also being, supported by Side by Side and other organizations. Then with regards to mass vaccination, what's the World Health Organization actually saying? So mass vaccination, and that's why our campaigns, I said, has been hijacked this year. We need to put them on hold for the time being, because there is a risk of community circulation where you have crowds of people coming to one place. Then just a little bit on resources available. There's resources available. As you can see, we've got an app where you can access all the essential medicines list and standard treatment guidelines, which include our vaccination schedules. Then we also have a very good information center, Amayeza. So they provide lots of information to healthcare professionals as well as patients. And they also have an app that you can easily download onto your phone. Then I just want to quickly mention this in terms of our future vaccine that we all are waiting for. Here's some interim advice from the Joint Committee on Vaccination in the UK, and it is actually based on UK epidemiological data. So at the moment, it looks as though priority will once be first for healthcare workers or frontline workers, healthcare workers, and then people with increased risks of serious disease. But very important, I mean, these are only interim because we don't have a vaccine yet. We don't know how safe the vaccine will be and so forth. We also don't know what we will have available in terms of vaccines, and what will the supply be and will it be able to meet the demand. So these things will change. So as we are preparing for a future vaccine, we try and maintain our immunization program to prevent vaccine preventable diseases. It's good because we are building infrastructure so that we can roll out our future COVID-19 vaccine. But saying that, The question is, how willing and confident will people be to accept this vaccine? So we don't, in South Africa, we don't have published studies where we have actually measured vaccine hesitancy. But as you can see from this global, Wellcome Global Monitor report, 74% of South Africans trust their doctors and nurses the most for medical advice, but 5%, 9%, and 11% think vaccines are unnecessary, unsafe, and ineffective. So with regards to vaccine hesitancy, which was last year identified by the World Health Organization as one of the top 10 threats to global public health, it is there, it is a reality, okay? So we need to take note of that and already put measures in place and plan strategies. How are we going to make sure that we increase confidence amongst people to be open and acceptable to receive the COVID-19 vaccine? So just a last note on the pharmacist. As I said, pharmacists play a very important role. In South Africa, pharmacists within the public sector and in community pharmacies will play a more important role as we move towards universal health coverage, because we are going to balance that equal health system that we have at the moment, and our primary healthcare sector will be expanded and into the public sector, in other words, into the private sector. So private sector facilities will render services to people who previously accessed services within the public sector. So we know that parents regard the vaccination-related advice given by their healthcare professionals as having the most influence over their decisions in terms of vaccinations. And pharmacists and they have been also in 2018, as I said, being celebrated as trusted sources of information. So we wrote this article in 2018 in our South African Pharmaceutical Journal, where we elaborated on the role that pharmacists can play in childhood vaccination. And we advocate for pharmacists to expand their role in vaccination in South Africa. So this includes all these aspects: communication, supply chain, cold chain management, advocacy, social mobilization, making sure we practice safe immunization. What about vaccine safety? Are we reporting adverse events following immunization? And then very important, monitoring and evaluation. If we don't monitor, we do not know how well are we doing, or do we need to put interventions in place. So the take-home message here today is pharmacists, our priority is to make sure we have high vaccination uptake, we maintain the integrity of our vaccination programs, and we have social mobilization in place. So pharmacists need to be knowledgeable about the science behind vaccination. And if you are knowledgeable, then you will feel more empowered to promote vaccination with confidence. And that's what we need, because we want to increase public confidence so that they will be acceptable to receiving vaccination and increase then vaccination uptake. So obtaining knowledge and keeping yourself up to date is actually key to creating a society where parents, as you can see there, this is what we want to see, parents walking the streets protesting if vaccines are not available, and demand it as a human right for their children, not to be hesitant when it comes to vaccination. So in South Africa, we have at our university, we have these two programs. This one is a higher certificate in vaccinology for all vaccinators, including pharmacists. So it's an online qualification that a person can do over a period of a year. And also coming soon as the lockdown is over, we will be presenting practical skills course for pharmacists and other healthcare professionals to make sure they have the right skills. So finally, I would like to encourage you to use each and every opportunity to vaccinate and spread the good news. that vaccines work, because we want to see this. I demand vaccination. It's my child's human right. So thank you very much, everybody, for listening. I'm leaving you with my favorite quote. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever does. And acknowledgements to everybody who's working hard to make sure that we have a continent free of vaccine preventable diseases. And then there's some references as well. So thank you very much.
Thank you so much, Professor Hanley, for that, again, another rich presentation. There's quite a lot we have learned from the South African experience. I think I want to jump straight to the questions. And I am going to start with Daniel Njuguna. Daniel Njuguna asks, this is to Professor Natalie, which is the current regimen, empirical treatment for COVID-19 in your country, and how is the prognosis? Can you recommend the regimen to other countries? So maybe we'll just take...
Thank you. So at the moment, it really depends on where you are in the COVID prognosis. So when we look at preventative, we don't have a preventative protocol. So we manage the patient. So ribavirin is a drug that is on Section 21 and not widely available. So at the moment, we are looking at lopinavir, ritonavir. If there's viral replication, we use corticosteroids, dexamethasone, in an ICU setting specifically. And then we don't really advocate for widespread vitamin C use, just based nilly-willy. And then the MABs, all of the MABs are super expensive. It's like tazolizumab, etc., where we can use in patients that are immune compromised or where we are really worried that patients may have severe side effects. And then colchicine is gaining wider acceptance. It seems as though there's a bigger appetite for colchicine. And then azithromycin is sometimes used in some of the patients, especially older patients, where they are worried about, the inflammatory storm as an immunomodulant. So maybe just to answer your question, it isn't a one-size-fits-all. It really depends on where the patient are in their disease presentation and also what their other risk factors are. We don't use chloroquine anymore.
Thank you. Thank you for that response. Dr. Elizabeth asks, what are your testing procedures, hospital, community, or pharmacies? I think it's also maybe just for me to ask, are you, is COVID-19, probably being tested in community pharmacies? I think it would be nice to know that as well.
Yes. Yes, it is. It's a mandatory reportable condition. And we've got specific sites. You call the National Department of Health if you suspect that you have COVID. In some instances, they send out healthcare workers to patients' homes. And then there are specific labs in the private healthcare sector. There are labs where patients can go. It's almost like in a parking area, which is cordoned off just for COVID-19 patients to test. And then we also have 53,000 not healthcare workers, but voluntary workers that has gone into the community. It's almost one of the first countries in the world where we go and do nationalized testing within the communities. So we've got well-structured places for testing, and suspect that's also why our numbers are so high.
All right. John Moura asks, can we give prophylaxis against the cytokinin storm and microclots to COVID patients, just from your experience?
Yes, so for the microclots, yes, we do. We use low molecular weight heparins in those instances. And then in the cytokine storms, we can use immunomodulatory effects, mostly dexamethasone in these patients. And then in some instances, they can use some of the MABs and then also corticosteroids, the MABs, and what was that other one, and colchicine. But then mostly if we are suspecting, just the rest of the question, if we are suspecting that the patient is going to go into a coagulation cascade, we use the low molecular weight heparins as anticoagulants.
Okay. There's a question here to Professor Meyer again. Daniel has noticed an upsurge in the demand for influenza shots in the beginning of 2020 when COVID was declared a pandemic. What could be the possible reasons? Probably a relationship there.
Okay, yes, yeah, definitely there was a huge demand because, I mean, we all know that influenza vaccination won't protect you against COVID-19. Although I must say we had many questions from the public on that. So I think from the public's point of view, people also thought that, but what we have been advocating for is that, you know, if, especially now, as we are moving into winter and, you know, the possibility of influenza is now increased, or it's more likely that you could get influenza, is to protect people so that you do not end up with two, you know, outbreaks at the same time. So it's basically to protect people, and that's what we have been educating people on, to get the influenza vaccine for that reason specifically. So I think that is why it's basically just to protect people so that you don't, and that's what we have been communicating. So that's the reason for the upsurge.
Okay. There's an anonymous attendee who is inquiring here that we rarely hear about fecal contamination in our campaigns. Is that an area we need to focus on, especially, you know, in certain areas, probably in sub-Saharan Africa, where sanitation is also an issue? And I think I also want to ask a follow-up question on that, on transmission through the eyes. I think I saw it in one of the slides. And maybe you can just shed some more light on transmission through the eyes, because this is something that, you know, when they really focus on masks and other forms of risk transmission measures, they really don't say much about the eyes.
Okay. Oh, is it for you, Annelie? Is it for you?
No, Natalie, I just wanted to say, Natalie, you're going to answer that one.
Okay, so yes, the gastrointestinal tract is a very welcoming environment for the virus. And some of the immunofluorescent data has showed that the ACE2 protein, which is now, we've said, the cell receptor for COVID, is abundantly expressed in the glandular cells of the gastric duodenal and rectal epithelia. So we know it should be an area that we focus on. And remember, any area that's got a vascular site, so the eyes especially as well, remember, would also be a welcoming site for the virus, but especially the gastrointestinal tract. So for both of your questions, yes.
Thank you. So there's a question here to Professor Meyer by G.K. Sur. Is there any correlation between vitamin D and vaccinations?
I don't know actually what you mean by that in terms of protection, probably, but I mean, you can only be protected against any vaccine preventable disease with a vaccine to initiate that immunity, you know, from in your body. But if you refer to COVID-19, maybe Natalie can also come in here with regards to vitamin D. I mean, we do not have good evidence. We do not have randomized controlled trials, as far as I know, in terms of the value of vitamin D. I don't know, Natalie, if you would like to say something about vitamin D?
Yes, okay. So thanks, Annelie. So I think when it comes to vitamin D and vaccine responses, is we know that vitamin D is implicated in numerous immune functions. So that's why it also correlates to corona. So it activates naive T cells, gene expression, and it also has a role in proliferation and differentiation of cells. But when we look at something like corona, the antigen presenting cells and the lymphocytes express this 1-hydroxylase, which we use to activate vitamin D actually. So we know that it has a role in immunomodulatory mechanisms. And we know that people who are vitamin D deficient are more susceptible to infections such as tuberculosis and other respiratory infections. So we're all worried about vitamin D, but we know it doesn't have, there was no statistical correlation between vitamin D and vaccine response in terms of upregulating your antibody response to the vaccine. But then when it comes to vitamin D and in the prevention of corona, it actually plays a role on the renin enzyme that I spoke about earlier. So there, where we know it actually then upregulates renin, and then that could actually have higher levels of ACE2 enzyme. That's I can go into a lot more detail, but I don't know if we've got time.
I think that's a very good answer to allow also for, more stimulation by some of the people asking questions for them to dig deeper. Celente is asking, before the questions, recent studies show neutralizing antibodies declining after 2 to 3 months at this stage. Can people be reinfected, and what does that mean for herd immunity? Anyone can answer that?
Well, what I can say at the moment, we don't know yet. If you look at the recommendations that I've shown, or the sort of provisional interim recommendations, we do not have enough data on this available yet. So we need a lot more in terms of studies and following the trends in the data to be able to see that. I know, Natalie, you also mentioned something about it the other evening. I can't remember whether you mentioned something about it now, but at this stage, but yes, there has been some reports, but at this stage, we do not have enough evidence to say that you can be reinfected or not.
Yeah, there's quite a lot that we just keep learning every day from COVID-19. And I think it's just experiences again from different countries or different clinical settings that will keep adding up to the bigger picture. I also have a question here. How do pharmacists, because we really talked about certain pharmacists in South Africa doing quite a lot of work in immunizations, but how do pharmacists navigate current transmission reduction measures by government to provide public vaccination campaigns? How easy or how difficult is it to get out there with social distancing, masks, and still be able to effectively either talk to people or actually provide doses?
Well, at the moment, while we are still within the COVID-19 pandemic, and we still have lockdown measures in place, and also based on the recommendation by the World Health Organization, we cannot do any campaigns at the moment. So definitely, we will not be able to do campaigns. But other measures or other interventions that they are looking at, for example, is to have mobile units going around to pair, like Natalie mentioned, these community healthcare workers going out to do screening and so on, to also have somebody paired with those where you will then, on a very small scale, be able to interact with patients, to screen road to health cards and so on. So in terms of pharmacists, at the moment, they can't go out, I would say, and participate in mass campaigns, because we will not have mass campaigns at this stage. So they can only do it on a one-to-one basis as they see people coming into the pharmacies, or as they are counseling people at the hospitals, handing out prescriptions and so on. So that's basically where they can play a role now, but definitely not mass campaigns at the moment.
Yeah, that's true. Okay, James Kamau is inquiring about, are there any legislative barriers to COVID-19 vaccine development in South Africa?
Well, at the moment, as you know, we have some trials at the moment, and all trials and all medicines that need to go through our regulatory office, SAPRA. So as long as it can go through there, then you know, things can move forward. I don't know, Natalie, whether you have anything to add to this. But yeah, they are very strict, you know, all your ethical issues must be in place, ethical clearances. So they are very strict on that. So as long as those things are in place, but there are trials at the moment in South Africa.
Yeah, there's quite a few questions being posted out here, and I think some of them are quite large, which also just says that people are really interested in these discussions. I might just take one more question here from Wesley Mugambi, who asks, are you doing any antibody testing in South Africa?
So at the moment, we've just received approval for one kit that was approved by the FDA. It was recently, it happened maybe last week. So now we are not largely testing for antibodies based on what Stelenta has also asked. We're not sure how long the antibodies are surviving, but it's modeled on the bigger coronavirus. So the original coronavirus. So we're modeling this virus on that larger virus, but we just started, but it's not widespread, not yet.
Thank you for that. I think I'm also looking at the time, and we are way past the time, but nevertheless, I think we have really benefited from your presentations and your times. Professor Natalie and Professor Hanneli Meyer from the School of Pharmacy and South African Vaccination and Immunization Center, Sefaku Magaku Health Sciences University. We really want to appreciate you coming and sharing with us your experiences and expertise in COVID-19, as well as vaccination and immunization among pharmacists. I just want to also recognize the presence of pharmaceutical technologies, which is another cadre in our country, and they're all in the forum. Also other cadres that might be in the forum, like nurses or other healthcare workers who have participated in this webinar. Remember that the Pharmaceutical Society of Kenya is carrying out these webinars every week and inviting speakers from different facilities, now also from different regions in the world, just to share with us. I want to appreciate everyone who has put together this webinar. Peter Odhiambo, the CEO of the Pharmaceutical Society of Kenya, and, Dr. Daniela Munene, and my co-moderator, Dr. Sylvia Opanga, and everyone else who made this happen. At this point, I want to say thank you and hand over the webinar to Dr. Daniela to close. Dr. Daniela?
Thanks, Mike. It was really an incredible forum, and we learned a lot. I just want to remind the participants that you should look out for this event on the PPB portal. There's been a delay in the event appearing due to some system changes. So if you want your CPD points, please keep checking in the course of the day for this event. I'll join Mike in thanking our distinguished panelists for being available to speak to us today. I'll remind our participants to join us next Wednesday at the same time. Next week, our speaker is Dr. Evelyn Wesangula, who is the IPC focal person at the Kenya Ministry of Health, and she'll be talking to us about IPC in COVID-19 and the role of the pharmacist. So from me and PSK Secretariat, it's goodbye and good day to you all. Thank you.